invite Associate Professor Ravi Kumar, who's from Peter Mac, for the next presentation.
Yeah, thanks very much. Thanks for joining the meeting. So my topic is slightly esoteric, non-metastatic prostate cancer. And really, this is more in the castrate-resistant setting because we've heard a lot already about biochemical recurrence and staging and so on. So the definition of non-metastatic CRPC is really based on no metastases on conventional imaging with biochemical progression despite sufficient ADT. There's also a high-risk category of this, which is based on PSA doubling time as well as the initial Gleason score. So it's really quite a niche area of prostate cancer, and the first few minutes of my talk I'll sort of explain the clinical significance of it and where it all fits in. So obviously you've got non-metastatic disease which then progresses to metastatic disease. As you all know, you also transition from hormone-sensitive to castrate-resistant disease, and you have a whole range of treatment options for all of these phases. So where do we fit in here? Is this narrow space here where you're transitioning from hormone-sensitive to castrate-resistant, but you're still non-metastatic on, conventional bone scan and CT. So this happens in about 8% of patients who are on ADT. So it's not rare, but it's an unusual disease state, really based on imaging definition. It's become more important because we've had a number of clinical trials in the last few years which show that this sort of disease state can be effectively treated with newer generation anti-androgens. What is the prognosis of this non-metastatic disease? Well, it's actually relatively poor. So this is a Canadian study incorporating data which is probably a little bit outdated now with the new therapies available, but the median time to developing this disease state from primary treatment is about 6 years, and then from there the time to death is as short as a median of about 3 years, overt metastases in 20 months, and overt metastases to death can be even less than 1 year in median time frame. And all of this can be changed quite dramatically with the addition of anti-androgens. You've got 3 randomized trials which show that all showing very similar results, that metastases are delayed by a median of 2 years by initiation of anti-androgens in this so-called non-metastatic setting. It's not just delay to imaging metastasis. We've got this meta-analysis showing that metastasis-free survival is improved dramatically, but not only that, and most importantly, overall survival is also improved. So you must be thinking, this is a deadly disease, it's a treatable disease, how can it really be non-metastatic? And obviously it's not non-metastatic. And this is the largest study in this space with PSMA PET. It's a very unusual and niche indication for PSMA PET at this stage. This was a multi-center retrospective study published a few years ago. Peter Mac participated in this, but lots of German centers were involved. More than 8,000 patients were screened to come up with 200 patients who fitted the definition of high-risk non-metastatic disease. So the vast majority of scans performed were for other reasons, such as biochemical recurrence or, castrate-resistant CRPC for lutetium therapy, etc. What did we find? There's a large percentage of positive PSMA PET scans. So 98% of scans had a positive finding in the non-metastatic setting. About half of patients had local recurrence. About half of patients had pelvic nodal disease, and obviously you can have more than one finding, so the numbers add up to well over 100. 40% of patients had distant nodal metastases. 25% of patients had bone metastases in conventional imaging negative, and a small percentage of patients had visceral disease. So a large amount of disease of varying distributions. That was the key finding of the publication from 2019. What's recently happened is that these patients were then followed up for several years to look at the management and clinical outcome of whether the finding of the extent of disease on PSMA PET actually makes any difference. And this was published at ASCO last year and has been accepted for publication but not in print as yet in a journal. So what happened? So probably unsurprisingly, the patients who had pelvic disease, whether it's prostate bed or lymph nodes, a lot of them got local regional treatments. A good proportion of them also got systemic therapy, which is, as I showed you earlier, the recommended treatment for this setting. If we did find distant metastatic disease, most patients got systemic therapy. About half of them got ARSIs. Also, some regional therapies were used in some of these patients as well. Prognostic factors. So management was affected, but also, we looked at the prognostic value of that PSMA PET finding. So multiple factors were looked at, and we found that if there were greater than 5 distant metastatic lesions on PSMA PET, whatever treatment the patients did get, those patients had both a shorter metastasis-free survival on conventional imaging, as well as a shorter overall survival. As we've also seen in other talks, a high SUV max was also a negative prognostic factor and associated with worse survival. So take-home messages from me. Non-metastatic CRPC is based on conventional imaging. It's probably a disease state which may disappear in the future if the imaging guidelines change and imaging modalities evolve. But there are clinical high-risk subgroups within this, and this is a very treatable condition with metastasis-free survival and overall survival benefit with hormone therapy introduced early on. PSMA PET could have a role. It's not commonly used, but it finds disease in a lot of patients in this setting. The location of recurrence influences clinical management. It's not guideline-based, but once you find something on the PET scan, people act on it. And potentially the PET scan can risk stratify high-risk patients based on pattern of spread as well as SUV max. Thanks very much.